And now we are moving to the next talk. Actually, it is a case example series on the two-step strategy, and it will be a perfect continuation of the last topic. So the next talk is from United Kingdom, from Chiara Landolfo and Jen Barkov. Very briefly, Dr. Chiara Landolfo is Italian medical doctor and PhD, French and English speaking, is a consultant gynecological oncology surgeon at Imperial College London. She joined IOTA Group as well as IETA and USAS studies. And Dr. Jennifer Barkov, also from UK, she is a clinical research fellow and specialist obstetrics and gynecology at Imperial College, with clinical interest in gynecological ultrasound with early pregnancy, rapid access, and reproductive medicine. And the next talk is joint. This is a discussion and case example, classifying ovarian pathology.
Good morning. We are delighted to be part of Ultrasound Essentials. And my name's Dr. Jen Barcroft, and I'm a clinical research fellow at Imperial College Healthcare NHS Trust. And I'm joined by my colleague, Dr. Chiara Landolfo, who is a consultant gynecologist, also within Imperial. So this morning, we're going to be discussing a series of cases of demonstrating how you can use the various IOTA approaches to help classify ovarian pathology. We will be available for a live Q&A at the end of the session. So please, if there are any queries or any questions about the applications of the IOTA models or about the specific cases, then just hang on to them at the end and we'll go through them in the live Q&A. So we're going to kick off with the first case. It is interactive, but as this is recorded, you can answer the questions at home and see whether or not you're kind of getting them correctly remotely. So case number 1 is a 50-year-old lady who was premenopausal. She was a para 4 and she presented with intermittent abdominal pain. Of note, she'd had a previous cholecystectomy in her surgical history. So this was the mass that she had on transvaginal ultrasound scan. And you can see here that kind of taking a systematic approach to evaluating it, we have a unilocular cystic structure, so a one locule, no solid components present. It's got nice regular cyst walls. When we're assessing for vascularity here, we have got the window here for Doppler assessment with a low PRF here as demonstrated less than 0.6. And you can see there's no internal vascularity here. So this would be given what we call an IOTA color score of 1. Evaluating the size, you can see here that the size of the mass, the largest diameter was just under 62 millimeters. And the content looks anechoic, but you can see in some images it may look low level, and that's maybe just to do with the different ultrasound system catching a still image. So a systematic approach, as we did mention, this is a unilocular cystic structure, and the size was around 6 centimeters. No solid components. No acoustic shadows present. You may notice there is a bit of acoustic shadow here, but this is coming off the bowel, not coming off the mass. That's what we felt to be on dynamic examination. No papillary projections and a color score of 1, and no ascites present. So when faced with this type of mass, the first step is always, can we apply benign simple descriptors? Yes or no? So jot down whether you think you can apply to benign descriptors and which one would apply if at all. So a reminder of what are the benign descriptors. So they are all unilocular cysts. And in this case, we've got a unilocular cyst with an anechoic cyst content, smooth walls, and a diameter less than 10 centimeters. Therefore, benign descriptor number 3 would apply. So thinking about the two-step strategy, the first step in the two-step strategy is applying benign descriptors, which in this case they can apply. So then we go forward into what the management is. So because this is likely to be an almost certainly benign lesion, the recommendation is for conservative management. Now, clearly we're dealing with patients, we're not dealing with just looking at a mass in isolation. So this is a lady who presented with pain. So the recommendation in this context was actually to undergo surgery, the choice of which was also tailored to the individual. So we're dealing with a 50-year-old who had completed her family. And so the advice and discussion with the patient was to have a laparoscopic bilateral salping oophorectomy. And the reason for this, as again, is for pain, not because of concern that the lesion may transform into something abnormal or any concerns about its morphology. And this was then very much confirmed by the histology, which confirmed it was a benign serous cystadenoma. So I'm just going to hand over to Chiara to do case number 2.
Great. So in case number 2, we have a younger patient, 29-year-old lady, with 2 previous uncomplicated pregnancies. She was asymptomatic, but she had an incidental diagnosis of an annexal cyst. So here you can see the ultrasound moving from the contralateral ovary through the uterus, and here the cyst of interest. Now, Jen, if you could just, yes. So you can see that there is a cyst with this white ball inside, and we can see also the healthy ovarian tissue around. We can go around. So this is the lesion. This is the cyst itself, and here the healthy ovarian tissue. Okay, we can see some acoustic shadows coming also from the white ball. So here is the grayscale. You can see the measurement of the ovary and the measurement of the cyst and how it appears. And here is the application of the color Doppler. You can see that the box is placed on the whole lesion because the color score is assigned to the whole lesion. And you can see that the velocity scale in this case is low, 4.4 centimeter per second, and you can see that there is no vascularization. So we are talking about a unilocular cyst. Unilocular cyst means a cyst with no solid component, no septa, no complete septa. Consider that the mixed content is considered as content in iota. The maximum diameter of the lesion was 33 millimeter, no solid component, only one locule because we have no complete septa. There were acoustic shadows which were more visible in dynamic, no papillary projection and no vascularization, therefore color score 1, and no ascites. Now, first question that we have to ask if we want to classify this mass is if we can apply benign simple descriptors, yes or no. So if we go to the benign simple descriptors, we can look at them and we can see if any of them can apply. We are talking about a unilocular cyst, so we can see that actually benign descriptor 2 is applicable. So indeed, it is a unilocular cyst with mixed echogenicity, acoustic shadows, largest diameter less than 10 centimeter, and all this is in a pre-menopausal woman. So if you go to our flow chart of the 2-step strategy, step 1 is the application of benign simple descriptors. So yes, they are applicable. We go immediately towards the management. So we're talking about an almost certainly benign cyst, which could be treated with a conservative management according to the symptoms of the patient, discussion and counseling with the patient, concerns of the patient. In this case, remember, this was an incidental diagnosis, so patient is asymptomatic, and she was managed in an expectant way with conservative ultrasound over time and follow-up after time in 6 months in this case.
Great, so case number 3 is a 20-year-old lady who was premenopausal, and she presented acutely with abdominal pain and fever to the emergency department. Of note, she also presented with significant abdominal distension and discomfort. So this was the ultrasound examination. So this was a transabdominal scan because she was Virgo intacta. And you can see here that we have got on video, we can see we've got a large adnexal mass and we have got multiple locules, presence of a solid component. So we have a multilocular solid lesion. Now, you'll note, just to run that video again, you can see here that we have got some papillary projections projecting into the cystic area, just here. And we've also got a separate solid component. So therefore, we have a multilocular solid mass with the presence of papillary projections. And it was felt to have between 5 and 10 locules. And there was also the presence of acoustic shadows that was being cast off from the solid components, which sometimes is a little bit easier to see in dynamic scanning. But you can see here we have got some acoustic shadows coming off. Evaluation of vascularity. So again, bringing the box in, you can demonstrate vascularity within the solid component, and it was felt to have moderate vascularity on the basis of, you can see here, we've got definite blood flow within the solid component. So this gave us a color score of 3. This is just a 3D evaluation of the mass, which just kind of gives you an indication of large kind of cystic components in the presence of solid part within there. So a systematic approach would be, so this is a multilocular solid mass, which was 174 millimeters in size, with the largest solid component of 114 millimeters, 5 to 10 locules, yes, the presence of acoustic shadows, and more than 4 papillary projections. And I had a color score of 3, but no ascites were present. So can benign simple descriptors be applied in this case? So just to recap, we have a multilocular solid mass. And when we look at benign descriptors, the really key thing to remember with descriptors is that they can only be applied in the presence of a unilocular cyst. So we have a multilocular solid mass, therefore we don't even need to look at any other features to think whether these can apply because they automatically cannot be applied. So then what do we do next? So the second step in the 2-step strategy is the application of ADNEX. Now, the good thing about ADNEX is that it can be used with or without CA125. In this case, we used it without CA125, and it gave us, so these are the features that you input in ADNEX, and this gives us an output. Now, if you're not familiar with how to interpret this, what you're looking at is what is the risk of malignancy for this specific patient. Now, in this case, the risk of malignancy is 58.5%. And then we've got relative risk of what is the likelihood of a specific subtype of tumor. So the categories are borderline, stage 1 ovarian cancer, or stage 2 to 4. Now, in this case, the highest relative risk is for a stage 1 ovarian cancer. So that kind of gives us a bit of more information about not only is this likely to be a cancer, but what is the type of cancer that we're expecting, because this can help to inform the counseling process and then the recommendation in terms of surgery. So thinking about the management, so we could not apply the simple descriptors in step 1. We go to step 2 with ADNEX. We have a high risk of malignancy, so between 50 and 100. And then the recommendation in this case for management is to be managed in a specialist gynecology oncology center. Now, this is where she was managed, and she underwent a left-sided salping oophorectomy because she's young, she's 20, plus peritoneal biopsies and a mentectomy. And the histology was confirmed to be a mixed germ cell tumor, which is again what you might expect based on her age and demographics.
Ready for our 4th case. We are talking about a 33-year-old lady who came to our attention because of intermittent pelvic pain. So this is the annexal lesion which was identified on ultrasound. You can see it is quite big. It shows complete septa, does not show solid tissue. You can see that there are some shadows coming from the septations. You can see that the content is low level. Okay, so if we look at how to describe this lesion and how to classify it, we said presence of complete septa and no solid component. So this lesion is a multilocular lesion. This quite a large lesion measured 94 millimeter. We said that there are no solid components, so the size of the largest solid component is 0. There were more than 10 locules. There were acoustic shadows, no papillary projections. We said there are no solid component. There was a color score of 2, which means minimal vascularization, just because there were some sputovascularization around the cyst wall and the septations. There was no ascites, and we knew the value of CA125, which was 24 kilounit per liter. Now, we should classify this lesion, benign versus malignant. First step, we know, is the application of the benign simple descriptors. Are they applicable? Yes or no? Again, it is quite straightforward. We remember that the benign simple descriptors refer to only unilocular lesions. So benign simple descriptors in this case are not applicable because we are talking about a multilocular cyst. So then we can go to the application of the ADNEX model in the two-step strategy. We can try without CA125 and with CA125. Now, without CA125, the risk of malignancy in our patient is 1.8%. So it's a low risk of malignancy. If we add the CA125, we can see that it does not change really a lot. It is 1.9%. Now, how to interpret this value in terms of management? We can go to our flow chart. First step, application of benign simple descriptors, not applicable. So then we apply ADNEX model as a second step. We have a risk of malignancy, which is between 1 and less than 10%, which correspond to a low risk. So this patient could be treated in a local gynecology center. She was symptomatic. It was quite a large cyst, if you remember the size. So she decided to undergo surgery and the removal of the cyst, and it was confirmed to be a benign mucinous cystadenoma. Ready for the next case, Jen?
So this is a 28-year-old premenopausal lady who presented with intermittent pelvic pain. So this was the lesion on transvaginal ultrasound scan. And you can see here on dynamic scanning, we have got the presence of, definitely the presence of more than one locule. So we've got a multilocular lesion. Now, the next assessment is the presence of whether or not there is a solid component. And you can see here that we have got an area where we've got lots of tightly packed locules. And the difficulty is sometimes working out, is there a presence of a solid part in there? Now, what we felt was that in that area where there is a very, very tight presence of lots and lots and lots of locules, that there was felt to be a solid component within that. So therefore, we have got a multilocular solid adnexal mass. Oh, seems to have frozen. There we go. So we've got a multilocular solid adnexal mass. And then in terms of size, so we've got a very large mass. Look, you can see here that actually it's outside of the ultrasound window. And then is there any other features present? You can see that we've got casting off of acoustic shadows within the lesion. So we've got a multilocular solid mass with acoustic shadows. solid component was felt to be around 54 millimeters, and it's a very large lesion. You know, we've got a 34 centimeter cyst here. More than 10 locules, yes, acoustic shadows present, no pupillary projections, color score of 2, so minimal vascularization, no ascites, and a CA125 level of 119. So can benign descriptors be applied? Now, I hope we're getting the hang of the two-step strategy and when to use it. So we have got a multilocular solid adnexal mass. Therefore, benign descriptors cannot be applied because we don't have a unilocular mass. So we then need to go forward to the two-step strategy, and we apply adnex in the second step. These are the features that we will extract from the lesion, and then we calculate adnex. So without CA125, it gives us a risk of malignancy of 14.1%. Now, what happens if we add in the CA125 level, which was 119? It gives us a risk of malignancy of 17.4%, so slightly increases it. Now, looking at what the underlying likely diagnosis is, so looking at the highest relative risk here is of the likelihood that it's a borderline tumor. So this is the likely based on adnex, so it's likely to be malignant based on a threshold of, let's say, 10%, which is often the threshold that's used to define a risk of malignancy. And it's more likely to be borderline than a stage 1, a 2 to 4, or metastatic lesion to the adnexa. So there we use the two-step strategy to inform our classification, but also to assist us in terms of management where is appropriate to look after this lady. So based on our adnex output, we have between a 10 and 50% risk of malignancy. So this would give us an intermediate risk, but the recommendation is very similar to in the 50 to 100 category, that it should be looked after in a specialist gynecology oncology center rather than a local gynecological center. So what was the management? So she did go through surgery, which I think everybody would expect based on this is a 34 centimeter mass, and she presented with symptoms. And the underlying diagnosis was very much in line with what adnex said, which was this is a likely to be a cancer, and it was likely to be a borderline tumor. So we had a risk more than 10%, and the likelihood ratio, the relative risk, was that of a borderline tumor. So it's very much in line with what adnex felt as the output of the two-step strategy. So on to the final case.
Ready for the last one. 38-year-old lady on combined oral contraceptive pill. In her personal history, she had 2 surgeries for benign cyst in the right ovary. She was operated elsewhere. She reported there were always benign cysts. And she had no family history of cancer of the breast or the bowel or the ovary. She had some symptoms, which were abdominal bloating and some pain in the right iliac fossa, which was actually the reason why this patient was referred. So in this lady, we found 2 cysts, one in the right ovary, here you can see it, and one in the left ovary. Now, focus first on the right ovarian cyst. You can see that there are some complete septa. You can see that there are some solid components. They are protruding into the cyst cavity, so they are papillation. We know it because we measure it, and they had a height of at least 3 millimeters. You can see that there can be some shadows coming from the septa, and here you can look at the video. So we can identify still some healthy ovarian tissue around. We can see the papillations, we can see the content. It is a multilocular solid cyst with irregular walls by definition because there are papillations, and some shadows coming very, very thin coming from the septa. Now, this is our right ovary. and we can describe as a multilocular solid lesion. It was a small lesion, 2 centimeters, and the largest solid component measures 7 millimeters. We considered 4 locules, presence of acoustic shadows, 4 papillary projections. We gave a color score of 3. As you can see here, there was clear vascularization in the papillations, so at least moderate vascularization. No ascites. CA125 was 20 kilounits per liter. Now, just have a look also at the other cyst on the left ovary. Here you can see the video. Again, we have healthy ovarian tissue around, and then here you can see from the uterus moving towards the left ovary, you can see a cyst which is multilocular with some irregular walls, but no clear solid component. Again, a very small cyst, just with some small vascularization. So if we are going to describe it according to IOTA, we would describe it as a multilocular lesion, 3 locules, 21 millimeter in the largest diameter, no solid component. There were some acoustic shadows, there were no papillation. We were not sure if the cyst was completely non-vascularized, so color score 1, or minimally vascularized just on the wall, color score 2, and no ascites. Now, in this patient, we have 2 cysts, one on the right and one on the left. But in order to assess our risk of malignancy, we go for the one which is the dominant mass. So between the two, on one side, we have a multilocular solid lesion, on the other side, a multilocular lesion. So we go for the most complex, let's say, in terms of morphology, cyst, in this case, the multilocular solid cyst. Now, this is in general something that you can find in your patient with bilateral cyst, and this is also what you will do. So you consider the dominant cyst, which is either the one with the most complex, if I can use this term, morphology, or in case of the same morphology, you go for the one which is the largest one. In case of the same morphology and the same size, you go for the one which is the better accessible on ultrasound in order to evaluate all the characteristics and the vascularization. So now, can we apply simple descriptors as a first step to our dominant mass? Yes or no? Remember, it is a multilocular solid lesion. Here you can see the vascularization in the population. Should be easy by now. This is the last case. Benign simple descriptors are not applicable. Remember, they only apply to unilocular cyst. In this case, we are talking about a multilocular solid cyst. So then we can apply Adnex, and we can try without and with CA125. So without CA125, we look at our risk of malignancy. In our patient, it is 10.6%. And if we look at the results with the CA125, it is 11.4%. But if then we look also at the subtype of the specific type of malignancy, so we look at the relative risk, we can see how the risk of borderline tumor it is increased. So what we usually see when we apply Adnex is that the inclusion or exclusion of CA125 does not really change the risk of malignancy, the overall risk of malignancy, but the presence of CA125 can make the relative risk more accurate and can guide you maybe better in terms of counseling of the patient in terms of the specific subtype. So if we look at our flowchart and the two-step strategy, step 1, application of benign simple descriptors, not applicable. We go to step 2, application of Adnex model. So in this case, we have a risk between 10 and 50%, which brings us an intermediate risk of malignancy. So this patient has been already seen in a tertiary oncology referral center, and she was operated with bilateral cystectomy, ultrasound-guided procedure, and mental biopsies. And our dominant mass, our right side lesions, was indeed confirmed to be a borderline tumor. It was a seromucinous borderline ovarian tumor. And the one on the left side, it was confirmed to be a benign cyst. It was a seromucinous cystadenoma. So we finish with our cases. We hope that you find them interesting, but we are ready, of course, to answer to all your questions and maybe clarify some doubt and further discuss face-to-face. Thank you, Jen.
Thank you.
So Jen and Chiara, thanks so much for some great cases. Really enjoyed seeing those. And of course, they've illustrated a lot of what we've been talking about throughout this session. Now, it won't have escaped everyone's notice that we're running a little late. And as a result, we're going to just obviously change things a little bit. I'm afraid we're going to cut down the break, and we're going to finish this session in a moment and reconvene at 10 past the hour. That's 10 past 12 in UK time at the moment. Just giving you a short break to stretch your legs and make a very quick cup of coffee, and we'll be coming back at 10 past, and we'll be reducing the gynae MDT by a few minutes just to make up for that, to give you a proper lunch break. So it's just for me to thank all of the speakers. Simon, for staying up past his bedtime. I know you go to bed about 9 o'clock, Simon, I'm aware. Lil, Surgeon, Chiara and Jen, and also, of course, my co-chair, Inessa, who just great to have you on a ISUOG program, Inessa, and we hope to get you back soon as well. I hope you will have a quick break, and we'll see you at 10 past the hour, and I'll be joined by Ahmed Sayasna, my co-chair, and we'll be talking mainly about cancer, and we'll have a really interesting MDT, looking at case examples of gynecological malignancy. So see you all shortly.